Thank you, Megan. Thank you, Megan. I know we are recording this, and I apologize. I cannot come off of or come onto camera. For some reason, it's not allowing me to. So, but anyway, I am here, and I thank Dr. Al-Khatib very much for presenting tonight. We are very privileged to have him speak. He did receive his Bachelor of Science degree in biology from Ohio State University in Columbus. He attended medical school at the University of Cincinnati College of Medicine, where he received his medical degree, graduating in the top 5% of his class. He spent a lot of time studying, Dr. Al-Khatib.
Yeah,
He then went on to complete his internal medicine residency at Northwestern University in Chicago. Dr. Al-Khatib completed a subspecialty fellowship in gastroenterology at the University of California, San Diego. Beautiful weather. During his fellowship, he authored and published multiple publications in esteemed gastrointestinal journals. He also authored 3 book chapters in separate popular gastroenterology textbooks. After observing the benefits endoscopic interventions could have on his patients, Dr. Al-Khatib completed an additional sub-fellowship in advanced and therapeutic endoscopy at the University of California. And I will hand it over to Dr. Al-Khatib.
Okay, thank you for the introduction, and welcome everybody. Thank you so much for being here. I always enjoy these talks. This is not my first time I've given a talk about colon cancer at the Oak Lawn Library, but this is the first time I've done it remotely here. So, and I apologize if you're going to hear any background noises, including my 10-month-old who's crying downstairs, or the occasional motorcycle that passes outside. So I do apologize, but these are I think the things that come with remote presentations. If at any point there's any technical issues, please chime in. As you heard earlier, so I'm an interventional gastroenterologist. I'm in practice here in the southwest suburbs out of several of the hospitals in this region, and I have a special focus on GI oncology. So I deal with a lot of colon cancer, and I deal with a lot of endoscopic treatments for colon cancer, as well as other GI malignancies. So with that, we'll kind of go directly into the talk here, and I will try and kind of focus on the more pertinent issues here, but we'll make sure we leave some time at the end for any questions at any point. But I always like to start these talks by just kind of giving a little bit of a background, a little bit of a example here. I'm sorry. So this is a real patient. He's a 62-year-old community college teacher. He's an avid fisherman. He's got a medical history of high cholesterol, non-smoker. He's got 3 kids, and he came to it came to my attention after he had some blood work done by his primary care physician showing some iron deficiency anemia. This is a gentleman who really, per his own words, was, I'm too healthy and I'm too busy to see my doctor, and I've been feeling well, having no symptoms. So after, he was referred to me, we went a little bit more into his history. No family history of colon cancer. He's had no prior colon cancer screening, and we did a rectal examination in the office with occult blood, and we saw that he had some microscopic blood positive in his stool. So that, combined with his iron deficiency anemia, we decided to perform a colonoscopy. And unfortunately, during the colonoscopy, we came across a large rectal mass. This is a colonoscopic view of what a tumor, an example of a tumor of the colon would look like. And you can see the oozing of blood. You can see sort of the occupation of part of the lumen of the colon. And when we took biopsies of this, it confirmed that this was indeed a colon cancer. Now, we follow this up with a CAT scan, which is something that we commonly do after diagnosing cancer, especially of the colon. And it showed, unfortunately, that there was some metastatic lesions to the liver. We referred him to an oncologist as well as a surgeon, and he underwent surgery. He had a left colon resection as well as a left liver lobe resection, and received chemotherapy afterwards. So he had quite the fight, quite the long, drawn out approach here. And when we reflect back on patients like this and cases like this, which we see all the time, we always ask ourselves, could we have done something to prevent this? Could this have been picked up earlier? Could we have gotten to a point where the treatment would not have needed to be as advanced? And so that's kind of what some of the things that we want to talk about here. So I'm going to start by just kind of giving an introduction to colon cancer. Some of this may be redundant. Some of you guys may know this. Some of you may be survivors of colon cancer or have family members of colon cancer. So a lot of this may be sort of a refresher or things that you already know, but I always like to just start by getting an idea of what colon cancer is and how we just approach it before we then go into some details of management and prevention and screening. And my hope is that by the end of this talk, you have really enough information to be able to make sound, smart decisions about your health, to really take control of your health, because as we're going to talk about, this is a preventable cancer. And the patients that are taking steps to take control of their health are the ones that are really dominating this condition. And so let's kind of jump in here. So the colon, and again, this may seem rudimentary, but the colon has really a couple of functions. The main function is the formation of stool, and it does that through fluid absorption, as the food that you've eaten that hasn't been absorbed makes its way through your small intestine to your colon. Fluid gets absorbed. We have bacteria in our colon that helps sort of break it down, which plays some role in both our immunity as well as some of our digestive capabilities. And as more and more fluid is being absorbed out of the material that's in the colon, it becomes more dense, more concentrated, and forms stool. And by the time it gets down to the rectum, the rectum serves as a stool reservoir until we're ready to have a bowel movement. And when we talk about neoplasms or tumors, what are we really referring to? What we're referring to is uncontrolled, unregulated, proliferative growth of cells. So tumors, we kind of put the word out there very, very frequently, and a lot of times we associate tumors with sort of bad things. But I would like to give some examples of tumors that can be benign as well as malignant. And when we talk about malignant tumors, that's when we're really referring to cancer. So some things that are benign examples that you may not have known of, which are actually considered tumors, are things like warts, which are a proliferation, unregulated proliferation of skin cells or squamous cells. Fibroids, a lot of people know people who have fibroids or have them themselves, of the uterus. Polyps of various organs, which we'll talk about. These are benign examples of neoplasms. But when a neoplasm or a tumor transforms into a malignancy, what's happening is this unproliferated growth through a series of molecular changes at the genetic level, usually mutations, trigger this growth to become invasive, in which the cells break free from its confined layer or origin and start to invade into the deeper tissues, into the submucosa, into the blood vessels, into the lymphatics. And once they're in the blood vessels and the lymphatics, then these tumor cells can actually spread, and they can proliferate to wherever these blood vessels may decide to take them. And each tumor or each cancer has certain organs that it has a predisposition to migrate to or metastasize to. But that's when these tumors become invasive, become malignancy, become cancers. And obviously, any cancer that's spread from its site of origin obviously becomes much more difficult to manage. So when we talk about cancers, we talk about staging. And this stage is really what dictates the treatment. And this is for any cancer, not just colon cancer, but in general, An early stage is curable, whereas a late stage is not curable. And that applies to most cancers in general. And staging of a tumor, when it comes to the colon, depends on a couple of things. The first is the depth of invasion. Okay, so when it comes to colon cancer, the actual size of the tumor isn't as important as it is with some other cancers. It's more how deep is the tumor, and we'll talk about that in a little bit here. The involvement of lymph nodes. One of the first areas that metastasizing cancer cells go to before they spread to other organs is the lymph nodes. And when we have involvement of the lymph nodes, that has direct implications on our stage. And then finally, involvement of local or distant sites. So spread to liver, lungs, brain, bone, things like that. Those three things are what dictate the stage. Okay, so when we're talking about colon cancer has a very well-defined progression. So every colon cancer starts as a polyp. It starts as a hyperproliferative growth of the cellular tissue of the inner lining of the colon. And this growth forms polyps. Polyps can grow in size, and they can start changing from a tissue standpoint from what we call adenomas to severely dysplastic or high-grade dysplasia. And then from there, the cells become cancer or adenocarcinoma. And once this adenocarcinoma, if left alone, can start to invade and become invasive carcinoma. So colon cancers start as polyps, and polyps grow through a series of steps and through a series of transformations, which involve mutations that are occurring on the cellular level that cause one polyp to turn into cancer, whereas another may not. And that's what I have highlighted here is these transformations from a tissue to go to form a polyp, to then form a polyp with high-grade dysplasia or immediate precancer to cancer. These are all caused by mutations, gene mutations that are occurring on the cellular level. And you actually need to have, usually in the case of colon cancer, a series of mutations that occur for a polyp to become a colon cancer. A question that always comes up is, well, if I have a polyp, what's the likelihood that that turns into cancer, and how long does it take? We don't have a very clear answer as to what percentage of polyps turn into cancer, but based on a lot of natural history studies, we're suspecting it's somewhere anywhere from about as high as 10% of polyps can turn into colon cancer. So not all polyps do turn into cancer. But again, these numbers are a little bit difficult to interpret based on the studies because it's something that's kind of hard to study. We do have a good idea of how long it takes in general for a polyp to turn into a cancer. And we think that's somewhere around 5 to 10 years in general. There's definitely variations here. There's certain polyps or certain types of polyps that are more aggressive than others. Specifically certain polyps that are called serrated adenomas that tend to be on the right colon. They have a little bit of a different biology, for example, and maybe a little bit more accelerated. But in general, colon cancer, to go from a polyp to a cancer, is a slow process. And this is really important because we take advantage of that. And that's part of the reason that colon cancer screening is so effective, is because we have the luxury of a process that is relatively slow. The cancer has a precursor. That's a polyp. And that precursor is a slow process before it becomes a cancer. And so what we'll talk about here in a little bit is we can take advantage of that for our screening. So when we talk about symptoms of colon cancer, the most common things that you're going to see or hear about is blood per rectum. So bleeding in the stool is something that always should be evaluated. A lot of times it may be hemorrhoids, sure, but we live in a time frame where the incidence of colon cancer is high enough where we can't make that assumption. Even if we're at a younger age, like we'll talk about here in a little bit, we have to always evaluate blood per rectum because that's one of the most common first signs of a colon cancer. Abdominal pain, is a potential other sign. It's usually a chronic pain that's been there for a while. By the time people have abdominal pain, it usually means that something is relatively advanced. Another potential symptom is a new onset constipation or a change in the stool caliber, where your stool may have gone from normal to all of a sudden pencil thin, or you develop constipation out of nowhere, even though your whole life you've been regular and there's been no other changes. Weight loss, and that applies to any cancer, is always an ominous sign. Unintentional weight loss, where you're eating the same amounts, but you're losing weight and you don't know why. Loss of appetite, which is what anorexia is. But in some rare cases, you can have things like a bowel obstruction, or actually show up with a perforation, which means a rupture of the colon. By far and away, the most common presenting symptom of colon cancer is actually no symptoms at all, but perhaps a blood test that your primary care doctor does showing that you're iron deficient or you're anemic. So most of our patients with colon cancer, especially early colon cancer, don't have any symptoms. And if they do, it's maybe some mild iron deficiency anemia. Any of these symptoms should prompt you to talk to your doctor. This is an example of a CT scan here that shows where the arrow is. This is showing what we call an apple core lesion or a tumor of the right side of the colon. And you can see here, this is normal colon here, normal colon here. The tumor is right here. And you can see how it narrows the lumen, or the sort of the actual tunnel, which is your colon. And that's why sometimes we develop constipation, is because things don't pass through as easy and you get more bloating, and the stool caliber changes. These are just some statistics to just kind of serve as a little bit of eye openers here as to, colon cancer. Colon cancer is the third most common cancer worldwide, and it's the second leading cause of cancer death in the US. And roughly every 3 to 4 minutes, someone is being diagnosed with colon cancer for the first time. And every 9 minutes, someone is dying from colon cancer. The lifetime risk of developing colon cancer for just average population is about 4%. So if you look at the survival for colon cancer, 65% of patients currently being diagnosed with colon cancer will survive or have a 5-year survival. So this is, again, all stages, all comers of colon cancer, all the diagnoses that are being made. About 40% of these patients are succumbing to their disease within the first 5 years. That survival, however, is directly dependent on your stage. So the earlier the stage, the higher the survival. And this is what this chart sort of shows here. So if you look over here, localized disease or localized stage means an early stage, for example, a stage 1 or a stage 2. And the 5-year survival is actually above 90%, which is great. Whereas if you go to this little column here, which is a stage 4, meaning there's distant metastasis, again, the survival drops to a very, very low number of only 13%. So the stage here is very important. And again, the earlier this is picked up, patients do very well. A rising trend, which has been alarming over the past decade that we've noticed, is that the incidence of colon cancer is actually increasing in our patients who are younger than 50 years old. So there's been a 50% increase in rectal cancer in patients who are less than 50. The age group is about 20 to 49. And this is an age group that has been sort of outside of the ages that we usually screen for. And we think that this rise may be due to the rising incidence of obesity. It could also just be more of an issue of younger patients tend to not seek attention, or they tend to be uninsured, so they don't want to see a doctor. And sometimes they will then just present a little bit later. So this is something that has generated a lot of interest and has actually changed our screening age recommendations, which we'll talk about here in just a second. So I'm not going to spend too much time on this, but just a kind of a brief overview here of how we treat colon cancer. Well, the treatment depends on the stage. When you have a stage 1 disease, that means this is curative. And the treatment is either through endoscopy, which is something I would do, for example, where we could remove the tumor with the scope if it's a specific type of an early stage, or a surgery. A higher stage, such as stage 2, for example, those are patients that can't be cured with an endoscopy, but usually can be cured with a surgery. Stage 3 usually require a combination of both surgery as well as chemotherapy. Stage 4 is considered non-curative, and these patients usually receive what's called palliative treatments, meaning therapies that are meant to alleviate symptoms and potentially prolong life, but are not anything that is going to cure the disease. And just to kind of bridge through here, and if case, this comes up pretty often, the type of surgery that you have on the colon depends on where in the colon the tumor is. If it's on the right side of your colon, if it's on the left side of your colon, or is it in the rectum. But in general, if you have a tumor in the right side of your colon, you're going to get the right half of your colon removed, as well as the lymph nodes in that area. If you have a tumor on the left side, called the descending colon, you're going to get a left hemicolectomy, or the left side of your colon removed. And what generally happens is they reattach the parts of the colon that are left over. So in this case, the transverse colon gets connected to the sigmoid colon. Now, when we start talking about rectal tumors, meaning tumors that are down in the rectum, okay, these surgeries can sometimes be a little bit more complicated because the question that comes up with a lot of patients when they have to have a colon surgery is, am I going to need a bag? And for most patients, and what we're referring to by a bag is a colostomy bag. For most patients that have tumors outside of the rectum, you won't require a colostomy bag. When we have to do a surgery that is for a tumor that is very close to the anus, the closer to the anus that it is, the higher the likelihood that you may need a colostomy bag. But in general, the majority of patients are having tumors high enough or away from the anal canal that they're able to have surgeries that don't require a permanent colostomy. When we're talking about the non-surgical management for early cancers that we do with the scope, the reason we can have endoscopic treatment be curative is that part of the staging involves the depth of the tumor. And so when we're looking at colon cancers, this is your colon over here, and we have multiple layers of the colon. You have the innermost layer, okay, that's called the mucosa, and then you have about 4 other layers until you reach muscle, and then the fat tissue outside of the colon, and then adjacent organs. So when we're looking at these cancers, if we find a cancer, for example, that is very superficial, just in the inner lining, when we do a scope, we're able to remove that and remove that tumor completely. But anything that's deeper than that first layer cannot be removed endoscopically. But here are just some examples, for example, of a tumor in the rectum that we assess the depth using what's called an endoscopic ultrasound, where we can actually see the layers of the colon, see which layer it's involving, and see if it's something that can be removed with the scope. And when we find a tumor or a precancer or a polyp, for example, that is superficial, we have various techniques with the scope that we can use to remove them. Sometimes we use a snare to just kind of guillotine off the polyp. Sometimes we inject underneath the polyp or the tumor to lift it up so that we can then take that snare and cinch it off using cautery. Sometimes we can use a combination of different things. Why do we get colon cancer? Well, colon cancer develops as sort of a combination of a genetic predisposition potentially combined with some form of an environmental trigger. There's a lot we don't understand as to why some patients get colon cancer and others don't, but we do know there are certain risk factors that will elevate your risk for developing colon cancer. And so the way I think about it is there's things you can control. Those are the environmental risk factors. And there's things that you can't control, meaning the genetics, the genes, the DNA that you have that may predispose you to colon cancer. And so when we talk about the things you can adjust, we'll talk about a little bit of those right now. The first one is smoking, right? Smoking increases your risk for multiple cancers. But when it comes to colon cancer, the relative risk is 1.2. So you're going to be double the risk of someone who is a non-smoker. And this is something that's very well established. Excessive alcohol can also increase your risk of colon cancer, also by more than double someone who is a non-excessive alcohol drinker. And 45 grams per day is, a decent amount. I don't know, that's not a very practical sort of number to put up here. People are more interested in, well, how many beers is that, or how many glasses of wine? Nobody looks at their alcohol content in grams, but in general, this will probably relate to about 2 to 3 glasses of wine, or 1 or 2 cups of hard liquor, or 3 beers per night for a prolonged period of time. Obesity is actually a big one, is a big risk factor for colon cancer, and especially truncal obesity. Once your BMI reaches above 29, you have more than double, the risk of colon cancer as opposed to somebody without truncal or midline obesity. Diet has definitely generated a lot of interest in terms of risk factors for colon cancer. And what we're seeing more and more of, and more data for, is processed meats and red meats are considered a very high dietary implication or risk factor for colon cancer. Red meats in particular, there's even recent data just out from the past month where they've actually highlighted the specific genetic mutation or alteration that occurs in patients who have high red meat consumption that increases their risk of colon cancer. So it's been replicated now through multiple studies that red meat does increase your risk of colon cancer. But what increases your risk even more is if that red meat is processed. So processed meats essentially refer to any meat that's been manipulated in one way or the other from its original form, either for preservation or for flavor. For example, salami, smoked meats, beef jerky, things like that. These are things, bologna, hot dogs, big ones. These have actually double the risk of the carcinogenic factor of red meat, and low fiber, and this is actually this sort of a diet, a low fiber, meaning a diet where patients are not eating a lot of fruits, veggies, grains, and they're eating a lot of red meat and processed meat. This is a typical Western diet, unfortunately. And so the World Health Organization has actually classified red and processed meats as a level 1 carcinogen. That's the same level that they have for smoking. So a hot dog, bacon, salami are considered as detrimental in terms of cancer risk as cigarette smoking, which for the World Health Organization to go out and say that really, really says a lot, because there's always a lot of resistance from our industry, from the meat industry, as well as other high impact industries out there that have an incentive to push diets high in processed meat, to not have the World Health Organization or our local health agencies actually declare it as a carcinogen. So it's out there. Age, the older your age, the higher the risk of colon cancer. And that's because of just an increased risk of the mutations occurring. Our cells are less able to repair genetic mutations as well as they do when we're younger. So we're more likely to form cancers. and this includes colon cancer. Race. So race plays a role, and the role race plays is a little multifactorial because there is some confounding variables as to why there is a difference in the incidence of colon cancer among different races. But in general, African Americans have a higher risk of colon cancer, followed by Hispanics, followed by Caucasian. A big one, which we'll talk about, is actually your family history. So it's very important if someone in your family has a cancer to actually know what that cancer is. So this is something that has direct implications to your health and your family's health. So when it comes to colon cancer, we know that family history plays a huge role. And if you have a first degree family member, when we say first degree, that means either your parents, your children, or your siblings with colon cancer, you already have a threefold increased risk of colon cancer. So you would be considered what's called high risk. Now, the age at which that family member developed colon cancer is important. The younger they were when they had colon cancer, the higher the risk for you. So if, for example, you have a first degree family member that was diagnosed with colon cancer before the age of 50, you're considered the highest risk for colon cancer, and you have a 10 times increased risk from the general population. And so if someone in your family is diagnosed with cancer, you want to figure out how old they were, what type of a cancer it was, and that's something you want to bring up with your doctor, because this will have implications, as we'll talk about here in just the next couple of minutes, for you, for screening. So the family history matters. You can go from being average risk from colon cancer to being high risk for colon cancer. People who are high risk for colon cancer, these are the patients that really need to take their screening seriously, because this is where we really, really save lives. And so I can't emphasize that enough. Along the same lines of sort of genetics is something called inherited syndromes. And what that means is this is a genetic condition that is possibly inherited from generation to generation. These are certain diseases or syndromes that if you have that genetic condition or are born with that genetic condition, you will have an increased risk of colon cancer. And there's a variety of these different syndromes. The most well-known or famous one or infamous one is something called FAP, or familial adenomatous polyposis. This is a mutation in the APC gene, and it causes you to develop hundreds of polyps at a young age, usually in the teens or 20s. And these patients have a 100% chance to develop colon cancer by the time they turn 40. Another condition is called Lynch syndrome. This is a genetic condition that gives you an 80% lifetime risk of colon cancer, as well as other cancers as well. And it's due to a mutation in one of the genes responsible for repairing your DNA. And actually, Lynch syndrome cancers, colon cancers, it's not rare. About 5 to 10% of all colon cancers are actually due to patients who have Lynch syndrome or have the mutation that causes Lynch syndrome. And again, these patients tend to get diagnosed a little bit younger, in their mid-40s. The criteria, or when to suspect that you may have Lynch syndrome, is really based on your family history. Again, that's why it's so important to really just pin down your family about who's got cancer. If you have 3 or more family members with either colon, uterine, or ovarian cancer, if you have at least 2 different generations involved, so meaning one is maybe your parent and the other one is your grandma, and one of those was diagnosed before the age of 50, you meet criteria for Lynch syndrome. And you should talk to your doctor about that, because then genetic testing is available to see if you carry that mutation. And if you do, you can make educated, informed decisions on screening for not just colon cancer, but some other cancers. BRCA1 is a mutation that is most commonly associated with breast cancer, but it does impart a 5-fold increased risk of colon cancer. And so patients who have this are also considered higher risk for colon cancer. So these are, again, some examples of genetic syndromes that you may have based on, a family inheritance. that have big implications for you. Along a kind of a little different path is something called inflammatory bowel disease. So our patients who have what's called ulcerative colitis or Crohn's disease have a higher risk of colon cancer as compared to people who don't. And especially ulcerative colitis, especially patients who have had ulcerative colitis for many years, involving a large segment of their colon, they have the highest risk of colon cancer, up to 30%. So just to kind of summarize again, when we're talking about risk factors, there's the things you can change, the environmental things such as your weight, your diet, alcohol and smoking consumption. And then there's the things that you can't change, but are important to know about, like family history, inherited syndromes, and things like that. So, before we go into sort of the next step here, just to, again, to really bring it home, colon cancer is a relatively common cancer. Again, we're talking about one of the third leading causes of cancer death, a 4.5% lifetime risk on average for patients. This is a cancer that starts as a polyp and slowly grows, and then potentially spreads. And the survival of colon cancer is really dependent on the stage. The earlier this is picked up, the survival is directly related to that. And there's multiple risk factors that can help you calculate what's your risk. So with this knowledge comes empowerment, and we can use this to really sort of take control of our health. So part of taking control is screening. And what I'd like to talk about now is really, who should get screened, when, how do we do it, what are our options, and sort of how often. So, the rationale or the premise for screening is that if we're picking up something before symptoms develop, we are likely picking it up at an early stage. And that means it is curable. So screening for any condition means doing a test without symptoms. So you feel fine and you do a test to see if you have a condition that is prevalent in the society. And so with screening, our goal really, when it comes to colon cancer, is to try and prevent colon cancer and also prevent deaths from colon cancer. So we're not only trying to prevent, dying from colon cancer, meaning have stage 4 disease, we're actually trying to prevent you even developing cancer in the first place, okay, by picking up polyps, okay? So we have multiple guidelines and committees that are out there that help us decide who needs to be screened, how do we screen, and how often. And so that's the American Cancer Society, the American College of Gastroenterology, the AGA. So we have these medical societies who come together every several years and look at all the data, all the literature, and give us evidence-based recommendations that we apply in terms of screening. And the good news is screening works. So since the 1980s, colon cancer incidence has actually declined by 45%, except for those younger population patients that we talked about earlier. And that's because those patients were at an age where they weren't getting screened, because our screening started at age 50 or started at age 50. So since we actually started screening since the 1980s, we've dropped the colon cancer incidence by 45%, and the death from colon cancer has dropped by more than a half. These are actually phenomenal when it comes to cancers. And in fact, the screening for colon cancer is the most successful screening modality that we have for cancers out there, be it prostate, be it breast, be it lung. And this is a study from the New England Journal of Medicine that just showed that not only is it effective in, or colonoscopies and colon cancer screening effective in preventing deaths, but we're actually preventing colon cancer from forming in the first place by removing polyps. So this is a study that looked at patients that had polyps removed and compared them to a population of patients, who have not had polypectomies. And we see that there's dramatic improvement in survival, in the incidence of colorectal cancer, up to 90, 88, and 76%. So that's fantastic numbers in terms of a test that can actually prevent cancer. So what are these tests? What are the options that we have for screening? Well, we have some options, and these are the ones that are available out there, and we'll just kind of go over them briefly. And this can then help you have an informed decision-making discussion with your doctor or gastroenterologist about how you want to proceed. So the first one is stool testing. You guys have probably heard of this. It's essentially the least invasive of the screening methods for colon cancer. And that's where we take a small swab of your stool and put it on a little card. And then that card will change color if there is microscopic blood. And the goal again here is to try and detect microscopic blood, which is one of the first and most common signs of a cancer. Now, this test, called the fecal occult blood testing, or sometimes known as FIT, fecal immunohistochemical testing, is not perfect. The sensitivity, meaning how accurate it is in detecting or picking up, or how good it is at not missing cancer, I guess is the best way to phrase it, is anywhere, depending on the study, from 40 to 80%. The newer stool testing, which is called FIT testing, is a little bit better, up to 85%. But it's not 100%. And the problem, one of the criticisms of stool testing is that it is not as good for picking up polyps, okay? It's a little bit better for colon cancer or advanced polyps. When you have a stool test that's positive, the next step then would be to do a colonoscopy. People who get their stool testing as part of their screening have to do it every year. Cologuard is a patented commercial stool DNA test. So this is still a stool test. And instead of looking for microscopic blood, it's looking for a multi-target DNA. So it's looking for actually DNA that's shed by colon cancer. And this is definitely more accurate than the FIT testing or the FOBT. It's about 92% sensitive for cancer based on one study. There's been multiple other studies that have shown that maybe that number is a little bit higher, a little bit inflated, but we're still looking at numbers that exceed 85%. For polyps, it's about 40% predictive or 40% accurate. So again, as with the other stool cards, if this is positive, your next step is going to be a colonoscopy. This is something that can get mailed in. So you get it in the mail, specimens collected at home, you mail it back out. It has to be prescribed by your physician, and it is done by a prescription. And then finally, or not finally, but kind of centrally, should I say, is the colonoscopy. The colonoscopy is considered the gold standard for colon cancer screening, as well as for therapeutic intent. And so the colonoscopy, what that involves, for those of you who haven't had it, is it involves using an endoscope. So an endoscope is a fiber optic flexible over tube with a high definition lens on the tip of it, as well as multiple channels for light, suction, and devices to come through, which is performed usually by a gastroenterologist. And it's done under sedation. And the scope itself gets inserted through the anus into the colon, and the scope sort of then advances through the colon, and we get a full visualization of all segments of the colon, from the rectum, the left colon, the transverse colon, the right colon. The colonoscopy timing is usually about anywhere from 15 to 20 minutes and can take longer. The hardest part of a colonoscopy in general has been the preparation for it. And so the preparation varies from different gastroenterologists, but in general, you're going to be on a liquid diet the day before your procedure, and you will receive your bowel preparation the evening before. And bowel preparation, there's a whole host of different preps. In the past, we used to use Go Lightly, which is a 4-liter sort of gallon of fluid, and patients really did not like that very much. It was very difficult to tolerate. But nowadays, we have many options for low volume bowel preps, which are now up to maybe even just 64 ounces And we just recently had FDA approval of finally a pill-based bowel preparation, which is going to hit the pipeline pretty soon, where you take several pills that act as laxatives. So the large volume bowel prep is not something that is now sort of mandatory, and there are low volumes. You usually don't eat after midnight the day before your procedure, and you show up the next day. This procedure has the option to be done under sedation. Some patients don't want sedation. Most patients do. And that sedation is usually either a twilight, which is what's called conscious sedation, which means that you're asleep, but if we shake you, hard enough, you sort of wake up groggy. So it's not sort of the sedation that you'd get for a big surgery in most cases. Now, the type of sedation will also depend on your health. If you have multiple other medical conditions, a lot of times your gastroenterologist may have a discussion with you regarding alterations in the type of anesthesia that you'll get. The procedure time, like I said, is 15 to 30 minutes, depending on the quality of your bowel prep, if we find any polyps, if we're doing anything in there. And then the recovery is usually 20 to 30 minutes afterwards, and then you're on your way. The advantages of a colonoscopy is that in addition to being able to detect cancer early, most accurately, we actually have the ability to prevent cancer. And that's because we can remove polyps. We can remove those precursor lesions while we're doing the colonoscopy. And the nice thing about colonoscopies is they're so effective that when you have one done, if it's negative or normal, you don't need another screening test for another 10 years. So you can sort of kind of put it on the side, which is kind of nice. It's an extremely safe procedure where the risks are, we're talking less than 1%. Things like bleeding, perforation are extremely uncommon and usually are most pertinent if a tumor or a polyp is being removed. In terms of sort of what we see when we're doing the colonoscopy is sort of what you see here on the screen. We're moving our scope. The gastroenterologist is inspecting carefully behind every fold, every turn, and carefully inspecting all segments. They'll be washing off anything that's there, obstructing the view, and they can target their view and look very carefully. And that's sort of the colonoscopy in a nutshell here. So when the colonoscopist is doing these colonoscopies, they're going to find different polyps, and we have different morphologies for these polyps, something called pedunculated, depending on if it has a stalk or not, or flat or sessile. And this is some example of what polyps may look like. These are some sessile polyps. A patient here has about 6 or 7, all clustered next to itself. This is an example of a pedunculated polyp, kind of looks like a little mushroom. These can be very easily removed by accessing this little stalk here and cutting it off. And again, we use our different tools from forceps to snares to injection needles. And here's sort of an example of what a snare polypectomy looks like. This is the polyp here, and this is the snare device being carefully removed from the scope. And we sort of kind of cinch that polyp. We get to the base of the polyp and we close it so that we're making sure that we're getting all of the polyp within our grasp. And then we can use cautery to then go ahead and just cut that polyp or sever it and ligate it from the remainder of the colon, which is what you're seeing here. Okay. And once it's gone, you're left with a little base there. So a lot of times, we're going to see polyps that are bigger than what you just saw before. This is an example of a very large sort of carpeting polyp. And these are when things can get a little complex and we have to do maneuvers where we are using injections and multiple different devices to successfully remove this polyp. In the past, if a polyp was a certain size, we would send patients to the surgeon to get the colon, that part of their colon removed. But with advances in techniques, of endoscopic techniques, we're able to treat these with the scope and remove polyps as large as 4 or 5 centimeters with curative intent. And that's something that I have special interest in and I've actually received additional training in, is these advanced polypectomy techniques. But my point for showing this is size here for a polyp doesn't matter in the sense where there are endoscopic options for removal. This is an example of something that we don't want to see, which is when we come in and this is example of a polyp that's turned into a cancer. So now you see this big cratered, ulcerated rectal mass. This is a cancer. This isn't something that can be removed with the scope. But we take biopsies when we find this to confirm the diagnosis. We mark the area of where it is, and then we make sure that there's nothing else in the remainder of the colon during this time. So just kind of finally here, when we're talking about surveillance with colonoscopies, how often do you have to do it? Well, if you have no polyps, you won't, like I said, you won't need anything for 10 years. If you have maybe 1 or 2 polyps that are small, your doctor will tell you probably 5 to 7 year follow-up. Once you have more than 3 polyps, or if any of those polyps are large size, you're likely looking at a 3-year return. If any of the polyps that they remove come back and the pathologist says under the microscope they have what's called dysplasia, which is sort of the step right before cancer, these are patients that we pay extra special attention, and we usually bring them back in 3 to 6 months to make sure everything is gone. Another form of screening is called a virtual colonoscopy. That's a type of a CT. This is sort of kind of fallen out of favor just because you still require a bowel preparation. They pump a lot of air in through your rectum. It requires a lot of radiation as they do this. And essentially that develops a 3D picture of your colon. And if they find any polyps, they then send you for a colonoscopy to get them removed. And this is how polyps look like on the virtual colonography. I think in the future, we're looking at hoping to find a blood test rather than a colonoscopy or a procedure. And we'd really like to find high risk, who's the highest risk for colon cancer, so that we can enroll them in screening much earlier. So just to kind of wrap up here, what can you do to take control of your health, take control of your colon? Identify your risk, figure out what your risk category is. Are you high risk or average risk? Talk to your relatives. Look for red flag symptoms. If you have any of those symptoms that we talk about, see your local GI. Okay, do not delay. Modify the things that you can modify. Cut out the smoking, lose the belly fat, cut out the processed meat, increase your physical activity. All of these can, result in about a 24 to 70% reduction if there's no genetic predisposition as well there. There's some data that taking a baby aspirin daily may reduce your risk of colon cancer if you've been on it for many years, but there's some risks of being on aspirin itself. There's no evidence, there's some data saying that maybe vitamin D or calcium supplementation can help prevent colon cancer, but that hasn't really panned out in studies. But the most important, most effective thing that you can do is talk to your doctor and your local gastroenterologist about getting screened. I cannot tell you how many lives we are able to save just by a test that you may have to do just once every 10 years. The one thing that I didn't put in this talk here is that over the past 2 years, our guidelines have changed, where we are now recommending colon cancer screening starting at age 45 instead of 50 because of that increased risk of colorectal cancer in younger patients. And this came out by the American Cancer Society, which then the GI societies followed suit. And now finally, the insurance companies are also kind of jumping on ship with this as well. But let me pause there and see if anybody has any questions. I hope I didn't go over time. But yes, let me open it up for any questions at all.
There's a couple of questions in the chat, so I'll go ahead and start with those. You just answered the first one. What is the age you should schedule your first colonoscopy?
So the age for the first colonoscopy is going to depend on your risk. So if you're average risk, you should start at age 45 now. Now, if you have a family history, you're considered high risk, and you should start 10 years sooner than when that family member was diagnosed with colon cancer. So for example, if you have a father who had colon cancer at age 50, you should be screening at age 40, okay? And so that applies to first degree family members. You have a brother that had colon cancer at age, 52, you start at 42. If you have any of those genetic conditions, such as Lynch syndrome, FAP, BRCA1, those are different. Those patients you have to talk to your gastroenterologist about, because you will start screening at younger ages, sometimes as early as 20 or 30. And the frequency in which you get your colonoscopy is going to be different. It won't be every 10 years if it's negative. It'll be a shorter interval. So I hope that answers that question. Yeah.
Next question, how dangerous are polyps?
So polyps, polyps vary. I think every polyp it's almost like a snowflake. Every polyp is different in terms of how it looks and its size. And in general, when we take out polyps, we send them to the lab and they tell us what kind of polyp it is. And they give us names like something called an adenoma or a villus adenoma or a serrated adenoma. And the danger of a polyp or the risk of that polyp turning into cancer depends on its size. The bigger the polyp, the more dangerous it is to becoming a cancer. The type of polyp, those different names that I mentioned earlier, some are more likely to form cancer than others. So in general, polyps themselves, not all of them turn into cancer. Only a fraction, maybe again, about 10, 15, 20% of all polyps, but there are some of those bigger polyps that have those different histologies that are the ones that have a much higher risk for turning into cancer. So when we see any polyp, we treat it as a potential bad guy. We don't want to leave any polyp in there because we don't know if that one is going to evolve, turn into cancer. So we don't want any polyps in you. I consider them all dangerous, armed and dangerous until proven otherwise.
Okay, next question. Is rectal cancer more associated with HPV?
Well, that's a great question, actually. So HPV, or human papillomavirus, is implicated in certain cancers. More commonly, cervical cancer is what we're most familiar with, but also more recently getting press is ENT, or head and neck cancers, so back of the throat, laryngeal cancers. The type of cancer that HPV predisposes you to is something called squamous cell carcinoma. And so the type of cancers that rectal cancers are and colon cancers are, they're a different type, they're a different cell type. They're called adenocarcinoma. HPV can increase your risk of anal cancer, okay, which is separate. That's different than rectal cancer, that's different than colon cancer. It's treated differently, it's staged differently. So HPV will not increase your risk of rectal cancer, but you can have an increased risk of squamous cell carcinoma of the anal canal through that. So good question.
One more question in the chat. You mentioned IBD, but is there any connection between IBS and colon cancer?
Yeah, that's a good question. And the answer to that is no. So irritable bowel syndrome does not infer an increased risk of colon cancer. And the reason is irritable bowel syndrome is a problem with the neurotransmitters that are responsible for the motility of the gut, the way the gut communicates with the central nervous system, how the gut perceives pain. But it is not an inflammatory condition. It's these inflammatory conditions that cause increased cell turnover. And when cells are sort of dying and regenerating, which is what inflammation does to cells, when that's happening a lot and frequently, that increases your risk of colon cancer. That's why Crohn's disease or ulcerative colitis increases your risk of colon cancers, because you're having a lot of this cell turnover. IBS doesn't do that. No cells are dying. There is no inflammation with IBS. So you're not at higher risk of colon cancer. Okay.
Those are all the questions I had in the chat. Does anybody
Okay.
else have any
Yeah,
other?
feel free to, unmute yourself. And if there's any questions that I didn't cover, it's a lot to cover in a short period of time. But so that's why if there's any questions, please chime in. And I've also included my office number, and this is my personal email. So if there's any questions that you feel more comfortable addressing privately, please don't hesitate to reach out to me. And I'm happy to get any patient or anybody who is interested in getting enrollment in colon cancer screening. I'm happy to talk to them about that and help make the best decision for them.
I have two questions.
Yes.
I've heard that after having gallbladder surgery, one can get colon cancer and that it often follows. Is that true?
So not to a degree that has been able to be confirmed on evidence-based studies. The changes that occur to your colon after having your gallbladder removed is that you have more bile salts, at least initially, more bile salts potentially reaching your colon in the first, years after having your gallbladder removed. And that's why some people, after they have their gallbladder removed, they have bouts of diarrhea initially, is because there's just more bile getting down there. And bile itself is not considered to be carcinogenic. So there has been no data to link that definitively. There has been some what we call anecdotal sort of examples of this, but nothing that on studies has really panned out. So it's not, having your gallbladder removed is not considered a risk factor for colon cancer at this time.
My second question is, at the deli counter, they have uncured ham. So that would be better than regular ham?
Yes, yes. So the processing of foods is and meats is one that can get a little confusing. So in general, first of all, red meats, including ham, already have a higher risk in terms of colon cancer. Now, not if if you have red meat, doesn't mean you're automatically going to go and get colon cancer. We're just talking about meals that are associated, or food types that are associated with increased risk. So ham in and of itself, as well as beef and red meats, already will have a increased risk of colon cancer. The processed red meats, like I said before, is going to be, really going to elevate things. So there's a lot of interest in delis and in food manufacturers to try and avoid the processing. Some processing, of foods is important and necessary and doesn't cause any issues. But a lot of times what happens when they process these foods is they add things like sodium, they add things like nitrates, they add things like sugars, for example, and that alteration is what sort of changes or increases that risk. So if you have a deli counter that is on top of that, they will offer some options for non-processed meat, and that will and definitely have a decreased risk in terms of colon cancer, for sure.
All right. Are there any other questions right now? Okay, I'm going to take that as a no. Thank you so much for being with us today, Dr. Al-Khatib. It was a great presentation. I really feel like I learned a lot, so thank you very much.
Of course, I'm glad you guys were here.
Yeah, and thank you to Sue Latosha for helping to set all of this up and connect us all together.
Great. All right, guys. Have a good evening. Oh, there you are.
There's Sue.
Yeah, I finally figured out where that button was. It's in a
Okay.
different spot. But anyway, I just want to thank everybody for attending. And Megan, thank you so much for always partnering with us. And Dr. Al-Khatib, your presentation was phenomenal.
Oh,
It
thank
was
you.
so informative. You are an excellent speaker, and please come back with us another time. You were
Always happy to.
great.
I'm always happy
Absolutely
to.
wonderful.
Anytime you guys need to, I greatly enjoy these, and I especially like being able to talk directly with the community and with our patients, and people that show up for these are usually the people that really take control of their health. They're the ones that are spending their time to actually, learn about their health. And these are patients that I've noticed in my experience, they just do better, they just do better overall. So I love those kind of patients. So I'm always happy
That's
to.
great. And they also pass the word on to their families and friends. So thank you for everybody who's here, and pass the word on to your family and friends. It's all great information. Thank you.
Wonderful. Thanks a lot, guys.
All right, thanks, everybody. Have a good
Have
night.
a good one. Take care. Bye-bye.